Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody for our first webinar about rare disease. It's a pleasure having our eminent speakers in the first wave talking about Gaucher disease, which is a very interesting topic, and it's a very, inshallah, good start for our rare disease waves. Our speakers today will be talking about the disease, what is it, and how we can diagnose, also the genetic part, and of course, in the end, the pharmacoeconomic that would be, inshallah, covered in details. Now, it's a pleasure always, of course, to talk about the efforts behind each webinar. I would really want to thank Dr. Ghada for her efforts and help in preparing the webinar. Also, of course, the Knuz Rotage for preparing the logistics, and of course, for Dr. Ayman for accepting our invitation, and Dr. Rauda for sharing with us her slides and her, inshallah, great thoughts and experience. Today, actually, what we are trying to do is, first of all, as you know, it's a rare disease. Most of us doesn't know much about it. So if you don't mind, our audience, we would like to just put some questions for voting to see what's the background of each one of us in the beginning. And then we want to see what's the result after we finish our talks to evaluate, did we reach our goal or not? And this would be, of course, inshallah, done by Dr. Ayman Hijazi. Now it's a pleasure to introduce Dr. Ayman Hijazi. He's our moderator today. He is a consultant hematologist. He's a reference in hematology in Saudi Arabia, the head of hematology unit in King Abdulaziz Medical City, Riyadh, treasurer of the Hematology Society. Dr. Ayman, the screen is yours.
Well, thank you very much, Dr. Fakhr, for this nice introduction. And I have sincere thanks to you for putting all this together and the efforts that you have put to make this possible. As you said, this is the first webinar of the rare disease series, first wave. So there will be, for the audience, there will be other webinars talking about rare diseases. And today's rare disease is Gaucher disease. We're happy to hear from three different speakers, inshallah, this evening, Dr. Ghada al-Gohari, Dr. Rauda Sumbul, and Dr. Fakhruddin. We'll go in details of each talk when it's time. But before we do that, as Dr. Fakhr has alluded to, we have a few questions for the audience to answer first. Please, if you can post the first question. These are poll questions. There will be multiple choices. Please answer the choice that you think most appropriate. This is, although it says Q3, but this is the first question. What are the possible symptoms of Gaucher disease? Fatigue, distended abdomen, increased bruising and bleeding tendency, bone fractures, or the above. Please vote. I guess we can put 20 seconds after each question. All right, do we see the answers? All right, so most people have answered 80% of the audience, all of the above. Well, all right, thank you. We'll see the correct answers maybe at the end, and then everybody will discuss that. So next question, please. All right, this is the second question. Type 1 Gaucher disease involves all of the following organ systems except the liver, the spleen, lungs, bone marrow, central nervous system. Okay, 50% have answered except central nervous system. All right, next question. All right, third question. Which one of the following cells is lipid-laden in Gaucher disease? Macrophages, lymphocytes, monocytes, plasma cells, neutrophils. All right, it seems that the answers are mostly macrophages, lymphocytes, and plasma cells, but macrophages in 34% of the answers. All right, next question, please. The gene responsible for Gaucher disease is GBA, GAA, GBE1, GBAP. All right, 43% for GBA, 24% GBE1. All right, thank you. Any more questions? I guess one more. Next question. All right, the diagnosis of Gaucher disease is established by clinical features, elevated biomarkers, C, enzymatic assay of glucocerebrosidase enzyme, diagnostic genetic test of GBA gene, genetic test of the GBA gene in 56%, that is followed by the enzymatic assay of glucocerebrosidase enzyme, 31%. Okay. Next question. So pharmacoeconomics pricing for orphan disease / drugs are by Marvok model, cost effectiveness, cost analysis, value-based pricing. Okay, we have a split between cost effectiveness and value-based pricing, 33% each, 21% by cost analysis. All right, thank you. I guess we still have one more question or we're done. Okay, that's probably the last question. So what's an orphan medicine? Is it a drug developed specifically to treat a rare medical condition, or a drug developed to treat patients, or a diagnostic test developed specially to rare medical condition, or an orphan drug that is still not yet developed? Please select the best answer. Well, diagnostic test developed specifically to rare medical condition, 42%, followed by a drug developed specially to treat rare medical condition. All right, thank you very much for the audience for participating in answering these full questions. I guess I'm sure the answers will be different at the end of the 3 talks, which we will hear shortly. So the first talk is by Professor Ghada Al-Gauhari. Professor Ghada is a hematologist at is a consultant in King Saud University Hospital in Riyadh. She is a professor of adult hematology in Ain Shams University since October 2016. She has so far around 60 publications and abstracts in peer-reviewed journals in different aspects of hematological and internal medicine disease conditions. She's also a member in many hematological scientific committees, editor, board member in many journals, and helps in reviewing of many publications. Dr. Ghada's talk today is about Gaucher disease from bench to practice. Dr. Ghada, the screen is yours.
Thank you so much, dear Dr. Ayman, for such a nice introduction. And thanks, Dr. Al-Fakhr, the president of Cardio Clinical Pharmacy Group, for allowing us to do this webinar series about the rare diseases. As you all know, the Rare Disease Day internationally is 28th of February, and we hopefully will celebrate it annually here in Saudi Arabia. And we will go to have a different webinar series about the rare diseases, starting from today about Gaucher disease. So my talk will have the following outlines: the epidemiology and the genetic of Gaucher disease, the pathophysiology of this disease, its classification, its symptoms and the manifestation, what is the differential diagnosis, and how can we early diagnose Gaucher disease before reaching to the late complications, and how we can apply the diagnostic algorithm in practice. So Gaucher disease is first, discovered in 1882 with this scientist in France. He was working in one of the midtown, hospitals in Paris. And to get his MD, he just had to do a thesis. And he did a thesis about a 32-year young woman who died with a hypertrophy in the spleen. Even he diagnosed it as if it is epithelioma in the spleen, which is tumor in the spleen, and don't know what is the disease itself. Later on an autopsy of this splenomegaly, they found this large cell, which is seen here. And later on, in 6 years later, they defined it as Gaucher cell for this scientist. What's the Gaucher disease? It's the most common lysosomal storage disorder with a prevalence of 1 out of 75,000 of the live births. It is autosomal recessive, and this is a cornerstone in the diagnosis of Gaucher disease. Due to what? Due to deficiency in a lysosomal enzyme named B-glucocerebrosidase, which leading to catabolism and accumulation in the glucocerebroside in the lysosome, which is the macrophages of the cell, leading to what? Accumulation of abnormal macrophages, which is heavily infiltrated with this abnormal sphingolipid, which is glucocerebroside, due to deficiency in the enzyme degraded it. And these macrophages, which is heavily burdened by the lipid, can cause accumulation in different organs, the bone marrow causing severe anemia and thrombocytopenia, in the liver causing hepatomegaly, and the spleen, as early mentioned, causing severe splenomegaly, in the bone causing bone fracture and avascular necrosis, as we are going to see. In the pathophysiology of the Gaucher disease, as I told you, it is deficiency in enzyme named beta-glucosidase, which is responsible for the catabolism of the sphingolipids on the cell membrane of the organelles, leading to accumulation of heavily infiltrated by this abnormal glycolipid. So the cell membrane is consisting of a glycolipid. The catabolism of the glycolipid done by the enzyme glucocerebrosidase and leading to the glucocerebroside, leading to its catabolism to glucose and ceramide. When this enzyme is deficiency due to genetic mutation, it will lead to accumulation of this glucocerebroside in the macrophages and in the phagocytic cell, and this is named as Gaucher cell. This is the picture of the Gaucher cell, which is a distinct phagocytic cell, as I mentioned, distinct by abnormal sphingolipid, and it may be distributed everywhere in the organs, causing its damage. It is look like a crumpled tissue paper, as if it is a crumpled under your hand, and it is a large cell, by the way, it is 100 micron, and it is a periodic acid shift stain positive. Under the microscope, it having a phagocyto elongation with a distinct lysosome containing this stored abnormal lipid. It is autosomal recessive, as we just mentioned. What does it mean? That means that the mother should be a carrier and the father should be a carrier. Being autosomal recessive, we should have a mutation of the both alleles of the gene carrying this enzyme production. And this gene is GPA1 gene, and will be discussed in details in the next talk, which is present on the chromosome of chromosome number 1. These two carriers, which is the father and the mother, having the possibility to have 25% of the offspring affected and diseased by Gaucher disease. And 50% of their offspring will be carrier like the mother and father. And still we have a 25% completely normal. This story is quite important to prevent the consanguinity. And if there is a consanguineous marriage of autosomal carrying, we can have a genetic testing for the offsprings. The overall population, as we mentioned before, it is 1 out of 40,000. It is more common in Jews. That's why it's more common in the States. And that's why it's more common in Europe. And it is primarily diagnosed in Paris. But still we have a genetic mutations which is specific to each disease. And here we underwent a study done by even Dr. Ayman Hijazi and eminent scientific scientists, which I'm going to discuss, that we're still having a misdiagnosed Gaucher disease in Saudi Arabia due to different unmet needs, which I'm going to discuss it in my talk. We should know that the phenotypic presentation of Gaucher disease is multiple variable with multiple clinical expression, and it is having a broad spectrum phenotype, meaning that if the one having a severe form of Gaucher disease might have a brother with a different mild form of the phenotype. This depends upon the genotypic modifying, which is discussed in detail in the second talk. That means that we have two brothers, as you see in this picture, both of them carrying the same gene mutation, both carrying type 3 of Gaucher disease, but still having a comparable phenotypic form. One is completely normal and one having a huge hepatosplenomegaly. What is the classification of Gaucher disease? We have 3 types of Gaucher disease. Keeping in mind the most common type is type 1, which is non-neuropathic form. It is common in young adult. It having a different presentation, might be presented as a childhood and might be presented in our adulthood in late 90s. It having a hepatosplenomegaly, it having all the symptoms of the Gaucher disease, but the most important that it doesn't have any nervous system involvement. Form up to severe form, and according to the glucose cerebrosidase activity, which could be less than normal by which percent. Type 2 and type 3 is the neuropathic form. Type 2 is the acute fulminant form, which might have a difficult in the life-threatening condition, hydrops fetalis, and the baby can die. And it is acute form, maximum, the age limited of this is maximum is 2 years. Type 3 is the chronic form, subacute neuropathic form. So we might have young adults, and it might live up to 20 years with neurodegenerative formation in the form of seizure, ataxia, and might be slowly progressive and might be only diagnosed in adult form. So the phenotypic variation of this Gaucher disease, making the type 1 might be asymptomatic and only diagnosed in the adult form. That's why it is misdiagnosed. Might be presented by a skeletal deformity. The type 3, which is a chronic neuropathic form, might be presented by any neurodegenerative form, Parkinsonian, delayed horizontal saccades, which is ataxia. Type 2, which is the acute lethal form, might have hydrops fetalis and intrauterine fetal death. And this is the neurodegenerative forms in the type 3 and type 2. There is further subclassification in the Gaucher disease, making type 2 acute lethal and type which can live for 2 years. Type 3 having another 3 forms, type A and B and C, and this will be important in the further slides for more diagnosis. As you see now, migration of the glucoceramide storing macrophage, which is now heavily infiltrated by the glucocerebrosidase, might be infiltrated in the spleen, tissue macrophage causing hepatosplenomegaly. The hypersplenism causes more cytopenia, causing the fatigue and hypermetabolic state. More bone marrow infiltration by this Gaucher cell causing more cytopenia, enter in the differential diagnosis of multiple hematological malignancy. The distribution of the macrophage, which is heavily infiltrated by the accumulation of the lipid in the liver, especially the Gaucher cell, not the hepatocyte. Hepatocyte is spared, causing severe hepatomegaly. In the bone, it impairs the function of the osteoblast, making the osteoclast very active, causing avascular necrosis of the head of the femur, osteoporosis, pathological fracture, and chronic bony pain. It might be presented as you see here, just in childhood and even till late 90s and 80s, because it has a different manifestation and a different involvement of different systems, whether in the bone by fracture, whether in the GIT by hepatomegaly, splenomegaly, which causing a huge pain in the left hypochondrium and early satiety, whether in the bone causing collapsed vertebrae, bony pain, bony crisis, or whether in the hematology by pancytopenia and anemia, and now enter in the differential diagnosis of multiple hematological malignancy. In adult, we have more the symptoms of fatigability, easy bruising and bleeding, menorrhagia in the female, decreased appetite because of huge splenomegaly, abdominal pain, with different variability of percentage as you see. More common is the hepatosplenomegaly in adult, to be followed by the anemia and the thrombocytopenia. And more common is the type 1, as I mentioned. Type 1 in adult is more common, to be followed by type 3C, as we are going to see, which might be presented by cardiac complication. While in children, you can have more than neuropathic form, as I mentioned, type 2 and type 3, and it might be fatal with hydrops fetalis. If they live with a chronic condition, they have a gross retardation, delayed pubertal development, marked splenomegaly, and the other manifestations of the adult. Now, more details about the other involvement, like the pulmonary. He can be presented to the Gaucher cell by interstitial infiltration, as you see under the microscope by autopsy, pulmonary hypertension, alveolar consolidation, and this pulmonary hypertension can cause problem in the heart too. While in the other organs, like the bone involvement, we have associated with bone involvement, as with overall disease manifestations, the severity of the skeletal involvement of the Gaucher disease cannot be relied on the GBA genotype. That means to diagnose the Gaucher disease, we have to know the leveling of the enzyme activity, which is the glucocerebrosidase, which is responsible for degradation of the sphingolipid glucocerebroside. It will not depend only on the molecular gene diagnosis. This slide just only to remember that in the bone, there is Erlenmeyer flask deformity, which is very characteristic in the Gaucher disease imaging, where the epiphyses are unaffected, the bone density reduced, diffuse, and localized, with compression collapse of the vertebral body. It could be presented even with nerve involvement and spinal cord affection. And this makes me enter in the differential diagnosis of the Gaucher disease with the spinal cord compression, and might be entered in another differential diagnosis, as we are going to see. In the liver, I told you before, the hepatocytes are not affected. That makes the liver function is completely normal in Gaucher disease, or even slightly abnormally affected. Having a splenomegaly and liver cell failure and portal hypertension, we can have esophageal pharesis and bleeding, which might be more aggravated by the thrombocytopenia, which is common in the Gaucher disease. Splenomegaly is very common in the Gaucher disease. As I told you before, early manifested of Gaucher disease was diagnosed as splenic epithelioma, as a tumor. And the enlargement is more common in the mutation genotype, which we're going to be discussed in detail in the second talk, 1226G, which is common to have immoral splenomegaly. The splenomegaly can cause abdominal discomfort, splenic infarction, and even white-shaped area of abdominal spiking venuses. And this problem was causing a problem in the 1991, where I don't have a proper treatment for Gaucher disease, and which pushes all the physician to remove this spleen and causing splenectomy to relieve the symptoms of the pressure. And this is a major mistake, because splenectomy without proper management of the Gaucher disease can cause acceleration of the manifestation and even lethal complication. The kidney is very rare to be affected in the Gaucher disease. Now, talking in the cardiac campaign, I have to attend the complication of the cardiac in the Gaucher disease. It's more common in type 3C Gaucher disease. It can be presented with variable picture as constrictive pericarditis, rheumatic aortic valve, aortic stenosis or mitral stenosis, calcification in the valve, diastolic heart failure, very rare to come as a myocardial infarction. And they found that this homozygous gene manifestations, which is present here in this case, having very common manifestation, dilated right ventricle, tricuspid regurg, pulmonary hypertension, and pericardial effusion. As I told you, it's common in type 3C. And this case was seen in my Egyptian campaign in Ain Shams University, where it is just poor in 1999 and presented in 2016 by dyspnea on exertion. His treating physician showed that his hemoglobin was 9 milligrams, that's why, and with mild splenomegaly, referred to me as being a thalassemia. By clinical exam, he has a murmur in the aorta, which is aortic stenosis. Neurologically, he was free. So I asked for an echo and enzyme assay, and it was found to have a second aortic valve leaflet and calcified annulus hypertrophy papillary muscle. The enzyme assay, which is the cornerstone in diagnosis of Gaucher, showed a very low level, 0.4 micrometer, and the ketotriidosase, which is one of the biomarkers will be discussed with Dr. Radwa in details, was saying that it's very active also. So it is Gaucher. The cardiovascular form, I did the metabolic gene. It was D409H, which is common to have a cardiac complication. It is homozygous allele burden. So it is presented with bilateral aortic valve and mild splenomegaly with corneal opacity and supranuclear ophthalmoplegia. Keeping in mind that I did a gene screening for the family, so it has a different phenotype, as we mentioned before. His brother was asymptomatic, completely asymptomatic. He reached to the age of 23 years old without any complication. And when examined, he has a mild splenomegaly, no anemia, but he has ophthalmoplegia, and he has a cardiac valve calcification with the same gene mutation, but the different phenotype. In the neurology, as I told you, common in type 2, type 3, different clinical presentation, different neurodegenerative changes with a different phenotypic presentation. It could be presented with cranial nerve, extrapyramidal tract, with strabismus, retroflexion. And in type 3, the first 3 years of life of the children might be presented with hyperreflexia, Kostyuk-Babinski sign, and this is misdiagnosed that it is not a Gaucher. The only thing to just diagnose it is to detect the enzyme level in the leukocytes in the peripheral blood. because this Gaucher cell is precipitated in the brain and causing these neurodegenerative changes, and the brain biopsy is very difficult in such young people. What I want to just focus on it being a hematologist, the problem is not only in being Gaucher cell precipitation in the organs, because when they took autopsy biopsy from the spleen, it presented only 1% of the heavily infiltrated Gaucher cell in the splenomegaly. The issue is that in the Gaucher disease, this macrophages, which is heavily infiltrated by abnormal sphingolipids, is presented to the immune system as antigen-presenting cells and causing the NKT cell and the dendritic cell to act against them and activating the B cell differentiation for more immunoglobulin production with the hypergammaglobulinemia and a picture mimic of a cytokine release syndrome, as you see, with hyperferritinemia. This immune dysregulation, if it continues to happen, it will cause a remote complication in the Gaucher disease, which might lead to multiple myeloma later on, hepatocellular carcinoma, very rare renal cell carcinoma. So for proper diagnosis of Gaucher disease, yes, it is presented to the hematology, adult or pediatrician, but it might be presented to the pulmonologist by pulmonary hypertension, to the gastroenterologist by hepatosplenomegaly, to the obstetrician by a problem in the pregnancy. I will see it later with you. By the ophthalmologist by corneal opacity, and by the neurology, as you see, just spinal cord compression, by also the orthopedic, by bony fracture, and by every problem in the avascular necrosis in the hip femur. And all of this should be minded that they should refer to the hematology, and may Allah protect us to proper diagnose the Gaucher disease being a hematologist. Is the scoring system, which is early managed for disease. I like it because it shows the severity of the Gaucher disease. Being divided into the score from 1 to 1.5 indicate that it is mild Gaucher, from 1.5 to 2 it is moderate, and more than 2.5 to 3 it is a Gaucher, it's severe Gaucher disease. As you see, it includes the skeletal survey, the bone marrow index, and the osteonecrosis and the fracture, the hematological type, meaning anemia, thrombocytopenia, the biomarker, which will be discussed in detail in the second talk, used in the prognosis of Gaucher disease, the spleen and the liver, hepatosplenomegaly, pulmonary hypertension. It doesn't include the cardiac complication of the Gaucher. Gaucher, to diagnose it, yes, the cornerstone is to have the leveling of the enzyme, but we use different imaging in the Gaucher disease, ultrasound, the MRI, in case of avascular necrosis of the hip femur, even the bone marrow examination to rule out hematological malignancies, the liver biopsy. All of this will burden the diagnosis of the Gaucher, and this will be discussed in the unmet needs with Dr. Fakhra Ayub in the last talk, how it is expensive to misdiagnose such a disease. A typical manifestation of Gaucher disease, by being a hepatosplenomegaly, thrombocytopenia, and anemia, it might enter in the differential diagnosis of multiple hematological malignancy, as you see here. It might enter in the differential diagnosis of hematological malignancy, acute lymphoblastic leukemia, multiple myeloma, lymphoma, CML, hairy cell leukemia, even, and myelofibrosis. Even it might enter in the differential diagnosis of idiopathic thrombocytopenic purpura, which is presented by bleeding tendency. Why it is presented by all of this? Because all of this having a bony pain, bleeding tendency, fatigability, hepatosplenomegaly, but they doesn't have a growth retardation. They doesn't have a Gaucher disease, but might have a pseudo Gaucher disease in the bone marrow. So the only cornerstone back again to diagnose a Gaucher disease is to measure the enzyme level. As you see here, the bone marrow, typical Gaucher, what is seen in the corner to the left, the wrinkled appearance. Keeping in mind, still I have what's known by pseudo-Gaucher cell, which is present in the hematological malignancy, the chronic lymphoblastic leukemia, the multiple myeloma, sickle cell anemia, and the myelodysplasia. Why? Because there is a rapid turnover in this dividing tumor cell and can give a picture which mimics the Gaucher cell. That's why we need an expert hematopathologist with me. I need the enzyme assay, and I need to follow up with the treatment by the biomarkers. The patient which I should suspect the Gaucher disease, that I have to rule out hematological malignancy, the hemolytic anemia, including the thalassemia, the bleeding intensity ITP, the splenomegaly and liver cirrhosis with portal hypertension, the infectious causes, the causes where there is hyperferritinemia, which is common also in the Gaucher disease and as inflammatory marker. So we have to rule all of this. And we have to do a schematic way in the diagnosis of the patient. Not all the patient I will do enzymatic level for it. I need to do a schema in my mind, and this is coming in the following slide. Gaucher disease awareness is a little bit very low among the hematologists. I'm not the one who says this. This is a European study done in Paris, and they discovered that when they presented a 42-year-old male patient, which is presented with bicytopenia, anemia, and thrombocytopenia, organomegaly, hepatosplenomegaly, and bony pain, the hematologist, 1 out of the 5 suspecting Gaucher disease and went through the proper diagnosis. But the rest, which is 4 out of 5, suspecting leukemia, lymphoma, multiple myeloma, other building tendency, and CLL. This is a problem of still we are misdiagnosing this rare disease. Also, it is the commonest lysosomal storage disease. We have to be proper-minded that we have Gaucher disease here in Saudi Arabia, even in my country, in Egypt, even in the Middle East. Yes, it's common in the Jewish, but still we have a good number of Gaucher disease, which we have to think over it and not to be only minded by hematological malignancy. This schematic pattern is very nice. Dr. Ayman Hijazi and the eminent scientist with him. And I'm proud to say that they published it in the American Society of Hematology in 2019. And this schema, if we are following it in my clinic, it will be very difficult to misdiagnose the Gaucher. Any patient presented with you with hepatosplenomegaly accompanied by bicytopenia, thrombocytopenia, and anemia, if there is element of growth retardation, if there is neurodegenerative disease, if there is Erlenmeyer flask deformity, so you have one and more criteria of CCS, you have to go to the proper diagnosis of initial screening of the enzyme. And now it is very easy to do it. Sanofi giving us a dried blood spot test. In details will be discussed in the next talk, how we can measure the enzymatic level in it. Besides, if you don't have any infectious disease to explain this high enzyme ferritinemia, and you don't have a bone marrow aspirate with any signs of hematological malignancy, suspect Gaucher disease. And frankly, I was lucky enough to see that they have succeeded to found almost 75 patients in Saudi Arabia. And they wrote that it is still not the proper number. We still misdiagnosed many Gaucher diseases in Saudi Arabia. Lucky enough that most of these 75, around 45, it is type 1, which is the mild one. 4 of them is type 2, and 26 is type 3. And this is the published in the Blood in 2019, and we are lucky to have Professor Dr. Ayman with us as a moderator. We can discuss it in details after the talk for the time sake. This is the dry blood test, and it's used for the enzymatic assay. And this is luckily enough, which is available by the Sanofi company, and it is only as simple by a just spot of the blood of the patient can measure the enzymatic level assay. Measurement of the enzymatic level acid B glucosidase can be supplemented later by the GBA1 gene mutation analysis, which is a molecular study, and even it's possible in Saudi Arabia. And we have this form away from the Sanofi after we do the try test, and it enters the differential diagnosis of other lysosomal storage disease, which is NIP and MEC and Fabry disease. This is a form of the gene present in the long chromosome arm in the chromosome number 1. As I told you, it is autosomal recessive. So to have a Gaucher disease, we have to have the mutation of both allele of this gene. And there is more than 400 mutation in this gene, as you see in this chromosome number 1. This will be discussed by Dr. Adwa in the next talk, inshallah. The biomarker of Gaucher disease is important in the diagnosis, but more important in the prognosis to know whether he's responding to the enzymatic replacement therapy, which I will discuss in the second slide or not. And these biomarkers, including the GL1, which is metabolite of glucoceramide, and also the plasma keto triosdase. And this is important to know whether the patient is responding to the treatment by the enzyme replacement or not. It will be discussed in details in the second talk. In summary, the diagnosis of Gaucher disease should be having a very well-minded hematologist. The early diagnosis, the early treatment by the coming slide will save the life of this patient from a severe debilitating disease complication. Splenomegaly thrombocytopenia is the most common symptom in Gaucher disease. Gaucher disease can be diagnosed or ruled out with the blood-based enzymatic assay to measure the acid beta glucosidase enzyme activity. It is available in Saudi Arabia using just a simple method, dried blood spot. In details will be discussed in the second talk. The combination of the specific algorithm mentioned before by our study and the enzymatic activity help you in the earlier diagnosis of Gaucher disease. The earlier is the better. Now, I am trying to finish my talk in the proper time, so I will discuss with you in the coming slide the treatment available for Gaucher disease. Since 1991 till before it, the only treatment was the surgical care, just splenectomy. Keeping in mind, splenectomy without enzyme therapy deteriorate more the condition. Why? You remove the burden that you will keep the more deterioration of the macrophage to be stored in the other organs, accelerating the more complication. Splenectomy only done after using the enzyme replacement therapy if the patient is still complaining from dull, aching, huge pain from the huge splenomegaly, not before. So the cornerstone is to give whether enzyme replacement therapy or whether substrate reduction therapy. Enzyme replacement therapy, it is an IV. It is a recombinant form of the enzyme which is deficient in Gaucher disease named glucocerebrosidase, and it is very effective. As you know, can be reversed, the visceral hematological manifestation of the Gaucher disease, but still there is unmet needs. I'm going to discuss it in the following slide. The substrate reduction therapy, it is an oral. It is FDA approved in 2014, which is after we discovered the enzyme replacement therapy in 1991. And frankly speaking, there is no study supporting it so much like the enzyme replacement therapy. The bone marrow transplant could be helpful, but now in the era of the enzyme replacement therapy, we are not using the bone marrow transplant to treat Gaucher disease. Gene replacement and enzyme enhancement therapy together with chaperone is one of the experimental study later on. It will be discussed in details in the gene therapy with Dr. Adwa, but keeping in mind that the chaperone is an experimental form to replace the abnormal unfolded enzyme inside the cell by a normal folded active one. The gene therapy, as you all know, we are starting here in Saudi Arabia to use it in the hemophilia, hopefully to be able to use it in the Gaucher disease. Just in summary, the treatment paradigm which is available here in Saudi Arabia is enzyme replacement therapy or the substrate inhibitor, which is not so much available. It depends on what the enzyme replacement therapy. The enzyme replacement therapy is replacing the deficient enzyme inside the body. So it helps in the degradation of the glucocerebrosidase together with the ceramide and glucose. What is the role of the substrate inhibitor? It prevents or inhibits the synthesis of the glucocerebrosidase by inhibition of the GL1 synthase. They are available in oral form, which is megalostat and eglostat. I will not mention the studies in it because it's not available and we don't use it in Saudi Arabia. Now, in details, I will discuss the enzyme replacement therapy for Gaucher disease. As I told you, it was available since 1991. And the first enzyme, which is the serodase or algurase, and it was introduced to reduce the accumulation of the Gaucher cell. The recombinant product, which is the amylglucosidase, which is the enzyme obtained from genetic engineering using the Chinese hamster ovary cell. It is developed in 1994, and it is introduced in the market in 1995. Frankly speaking, there is no head-to-head study to compare the different enzyme replacement therapy. But in our experience, the treatment with Cerezyme, giving a good options in the treatment, as I am going to discuss it in different study, and the doses is 30 to 60 units per kg every 2 weeks. The range of the doses might increase according to the severity to 2.5 units per kg 3 times per week, up to 60 units per kg once weekly, every 4 weeks. And this depends upon the severity of the disease. Administration, it's through intravenous infusion, typically take from 1 to 2 hour infusion time. It is safe And it is data which is done in the study showing the safety in the pregnant woman and prevent the complication of pregnant woman known to have a Gaucher disease. And it is safe and used in type GD1 and GD3. Safe and efficacy is proven, but there is still unmet needs, which will going to be discussed in detail in the third talk. What is my goals in using in this enzyme replacement therapy is to decrease the burden of the organomegaly, to decrease the burden of the pancytopenia, trying to prevent the pulmonary hypertension, and the early, the better. This is study showing that the 4 years using of this enzyme giving a very good results as regard the anemia, as the hemoglobin, as you see, it's increased, and in the platelet count, in the epithelial splenomegaly, it's decreasing in the size, even in the bony pain and in the bone crisis. What's important even is the life scoring is normalized through 4 years. If you remember the scoring system, which I mentioned before, it showed that in the treatment patient after 4 years with cis enzyme replacement therapy, imiglucerase showed a better quality of life, and it decreased in the scoring system, while the untreated is still complaining from the fatigability, from the bony aches, and from the social dysfunctioning. This enzyme showing a prominent visceral and hematological response, especially in type 3, which having the cardiac complications. And in the international Gaucher registry, it showed the effectiveness of this imiglucerase and the other alglucerase treatment within 5 years, and within the patient with type 3, which is less than 18 years, it improved the anemia, the thrombocytopenia. The unmet needs in this enzyme replacement therapy is the bony aches, or the bony manifestations, which is still not properly corrected or needs more time to be corrected. This patient, which is shown in this figure, was discovered while she was an age of 9 years before 1991, and she removed the spleen. After the spleen was removed, she has a hepatopulmonary syndrome, and she's an oxygen dependent, and the clapping as shows in the fingers. She was lucky enough that she lived in 1991 and started the enzyme replacement therapy. All the manifestation of the hepatopulmonary syndrome was improved. She was reaching to the levels that the only solution was hepatic transplant. No, by the enzyme replacement therapy, even the clapping disappears. The huge hepatomegaly disappeared. The pulmonary syndrome disappeared, and she luckily reached to the age of 21 with a normal manifestation. Now, just a note in the pregnancy, this enzyme replacement therapy, the imiglucerase.
Can we wrap up, please?
Yes, only 2 slides.
2 minutes behind time. It's okay.
Okay, only 2 minutes. It is safe in the pregnancy, and it improves the symptoms, which is the abortion and which is the Gaucher-related symptoms in the pregnancy. In the prognosis, as I told you, the skeletal disease. The lessons to be taken, that splenectomy never to be done without enzyme replacement therapy. The neurological symptoms and the bone disease is still unmet needs and still not properly controlled by the enzyme replacement therapy. Take-home messages, the Gaucher disease is uncommon, but still the most common lysosomal storage disease. Monitoring is essential together with a multidisciplinary approach. Early diagnosis and management prevent irreversible damage, and better to have awareness with the risk of consanguineous marriage. Why? Because there is importance of prenatal diagnosis. I can diagnose a fetus while still in the mother with a chorionic villus biopsy or with just amniotic fluid biopsy, and I can give her a choice of abortion. So just to detect it early is the better. Thank you so much. Shukran, Dr. Ayman, and sorry for taking much time. Okay, I will stop sharing.
Thank you very much, Dr. Ghada, for this elegant presentation, very extensive. You have touched in almost all the points. Well, I mean, we are almost 20 minutes behind time. I just want to comment on the diagnosis of Gaucher disease, if you allow me. I mean, we know, Gaucher disease, the problem, the main issue is diagnosing it. And it's definitely an underdiagnosed problem everywhere, especially in the Middle East, because of the rarity, and people don't tend to think about it. I guess, as you have mentioned in your slides, splenomegaly and thrombocytopenia are very important to look at and to have Gaucher disease back in your mind whenever you see a patient with these two symptoms. Now, not every patient with splenomegaly, of course, is a Gaucher, and not every patient with thrombocytopenia is a Gaucher. Based on the diagnostic algorithm, I mean, probably the most common reason for splenomegaly in the Middle East is probably liver cirrhosis, portal hypertension. And this has to be ruled out before going into the enzymatic assay. Thrombocytopenia, it has to be unexplained. Not the ITP, not the one that is associated with hematological malignancies, but unexplained thrombocytopenia. You may, and we have seen patients with unexplained thrombocytopenia or misdiagnosed as ITP, especially sometimes they get splenectomized, although the spleen is big, and people still insist that this could be ITP. Anyway, I will not take longer. There is only one question, Dr. Agada, we would like to ask. I mean, it's for pediatricians, but it's related to Gaucher disease. So this is a question from Dr. Amal Lawami. What is the developmental profile for children with Gaucher? Any developmental disorder that we need to look for? Any effect on learning or IQ?
Yes, there is growth retardation, late puberty. Even the curve is very affected. Even he cannot concentrate at work. And this is one of the eminent figures if it is a smart mother to detect it early in the child.
Well, thank you very much. Since we don't have a lot of time, we'll not go over more questions. It's my pleasure to introduce the second speaker, Dr. Rawda Sumbul. Dr. Rawda is a consultant medical genetics at Qatif Central Hospital, head of genetic unit, consultant medical genetics and general pediatrics. She's the head of the National Newborn Screening Program in QCH and peripheral hospitals. Dr. Rawda will talk to us about the genetics of Gaucher disease. Dr. Rawda, the screen is yours.
Hello, thank you very much for allowing me and inviting me to participate in this educational sessions of the educational webinar. And today also we're going to complete our talk about the Gaucher disease, focusing more on the diagnosis of Gaucher disease. And our talk will include. We'll just have an introduction about what are the lysosome and what are the lysosomal storage disease. And we're going to have like a very quick overview over the Gaucher. And we're going to focus more on the diagnosis of Gaucher disease. We call Gaucher disease is one of, we always say it's one of the the commonest lysosomal storage disease. And actually, we're going to talk about what are the lysosomes first. So the lysosomes is around the structure and membrane-bound organelles that are found in the cells. It's almost in all the cells except for the RBCs. This organelle was discovered by a scientist, a Belgian scientist called Christian Didove, and he got the Nobel Prize for his discovery in 1974. The main function of this lysosome, which is a spherical structure, which is a membrane-bound structure, is it's a hydraulic function. So it has no synthetic function. Nothing. So lysosomes they do not synthesize. They mainly do a hydraulic function, and they hydrolyze virtually all the kinds of biomolecules. So they hydrolyze the protein, nucleic acid, carbohydrate, lipids, and cellular debris. So how do so when the enzymes are done in synthesized by the endoplasmic reticulum, they are bound into a structure, a vesicle, and they go there to Golgi apparatus, where they got their we said glycosylation, which means adding the mannose 6-phosphate for the enzymes, and then these enzymes are released in the lysosome, which is this structure. So they have these lysosomes. They do 3 different functions. They do a phagocytosis, so they engulf all the outside bacteria and the viruses. They do an endocytosis, and they where they digest some food particles, and they do an autophagy. The autophagy, where they clean up all the dead tissue in our cells, or the dead organelles in our cells. So as we mentioned before, it's mainly a hydraulic function in the lysosomes. And then they have more than, the lysosomes has more than 50 enzymes, and these enzymes are kept in a cell membrane, as we can see here, that these lysosomes are a membrane bound because they are of acidic nature. And these enzymes, they work under an acidic nature of the lysosomes. And as we mentioned before, they engulf the food vacuoles, they destroy the bacteria, and they damage or get rid of any dead organelles or the tissue inside the cell. So as I will not repeat Dr. Agada, and Gaucher disease is the commonest lysosomal storage disease, and the incidence is we have the incidence in our countries according to the literature. It's 1 in 100,000 and more in Ashkenazi Jews, and it is, as Dr. Agada mentioned, it's an autosomal recessive disease. So consanguinity play important role why we have an increased incidence of the disease in our area. So the enzyme deficient is glucocerebrosidase, is one of the lysosomal enzyme. As we mentioned, these enzymes have hydraulic function, so it breaks down the glucoceramide into glucose and ceramide. Ceramide is one of the sphingolipids, which is kind of lipid. That's why we consider Gaucher disease as a lipid storage disease, because the ceramide is sphingolipid fatty acids. So this is the pathway that already has been mentioned by Dr. Hale, and this is, of course, the Gaucher cells that accumulate in different organs, and we have, we have differentiated from the pseudo-Gaucher that's found in hemoglobinopathies, malignancies, and mycobacterial infection. And of course, it affects many organs, the bones, the liver, and the spleen. And affects also importantly the bones. It has 3 different forms mentioned before by Did, which is type 1, the non-neuropathic, and type 2, the neuropathic, the rapidly progressing type of Gaucher disease, and this, of course, the type 3 that has 3 subtypes, and one of them is the cardiovascular, which this cardiovascular has an associated with homozygosity of this gene D409H mutation in the Mediterranean people. Of course, we have the type that is called the lethal form of the disease, that they present with the high drops, they present with hepatosplenomegaly, pancytopenia, and they present as a colloidal baby. So if you find a colloidal baby with an organ enlargement and sometimes with erythroglycosis, then this is possibly one of the storage disease, because high drops can occur in many storage disease, not only Gaucher disease, but also can present with Niemann-Pick, GM1 gangliosidosis, and other lysosomal storage disease. So non-immune high drops should the storage disease, and one of them is Gaucher disease, should be ruled out. So this one, I think Dr. Agada, she had already went through the types, and also the long-term complications that Gaucher is known to be associated with Parkinsonian, and mainly the cognitive type of Parkinsonian disease. And we have either the Parkinsonian or the dementia, and it's also associated with liver cirrhosis and portal hypertension, as well as, though these patients, they receive, they treated early, and with the ERT, they still have tendency for malignancies like multiple myelomas, hematological, hepatocellular, and renal cell carcinomas. So the diagnosis of Gaucher disease started with the clinical diagnosis and lab diagnosis. The clinical diagnosis, it starts from the history and then the physical exam. So the history, we ask about the consanguinity, whether the parents is the consanguinity increases risk of any inherited metabolic disease or inherited genetic disease. And also we ask the family about any patient who had died with liver disease or with hematological diseases. And also we ask about also the previous diagnosis of any family member from both family sides with a disease that affect the liver, spleen, or affect the bones. In examination, we will have, of course, a massive splenomegaly, and also when bone marrow done, because Gaucher disease, it goes under the differential of many hemato-oncology diseases, and also it goes in under differential of the neurodegenerative diseases. So we do, the bone marrow is one of the diagnostic tests that people go when the patient present with splenomegaly or thrombocytopenia. And then, of course, we should look for the Gaucher cells inside the bone marrow aspiration. So other diagnosis is the gold standard that established diagnosis of Gaucher disease is the enzymatic activity, which can be done in either the leukocyte, or we can have it in a skin biopsy, or we can have it in the DPS, which is the dry blood spot. And this enzyme activity, it's low in an affected patient. Do we do it for heterozygous or no? Because the enzyme activity in the heterozygous carrier and the normal individual, they show an overlap and are not used to differentiate any carrier from the normal individual. So after having a low enzyme, then we can go to genetic test and we can go to the markers. As we mentioned before, the bone marrow examination may be needed to rule out any hematological abnormalities, especially if this patient develop an enlarged lymph nodes or have some symptoms suggestive of hemato-oncology disease. Or we have, of course, the splenomegaly, which does not regress with the treatment. So we go to the lab test diagnosis. What we see in the lab test that we look for, we see the thrombocytopenia, the anemia, the leukopenia, which is the pancytopenia. Liver enzymes also may be elevated, and there is also deficiency of the coagulation factor causing an abnormal clotting. So the abnormal clotting not only by the deficiency of the coagulation factor, but also it has related to the platelet function problems, and they have a platelet adhesion defect, not aggregation defect, which contributed to the thrombocytopathy in a patient with Gaucher disease. And therefore, it will precipitate an increased risk of bleeding tendency in patients with Gaucher disease. So imaging play also important role in the diagnosis. So we do an ultrasound or we do a CT scan of the abdomen, looking at the organomegaly and determine the liver and the spleen volume. And we also sometimes can see what's called Gaucheroma, which is a focal accumulation of the Gaucher cells that will be seen in the MRI or CT scan of the abdomen. Also, a part of the diagnosis, the skeletal survey that we do for these patients, looking at the spine and the long bones. And of course, we're going to see the proximal tibial and distal of the femur, and we do the MRI of the spine and the femur, looking for the changes that we see, which is the hemorrhagical infarction, necrosis, the cortical necrosis here, and also the osteosclerosis. And we see sometimes the loss of the cortical bone. And as mentioned before by Victoria, we see the characteristic feature, which is the Illner-Meyer classic deformity. And of course, all these changes in the bone will lead to severe bone pain and will lead to a pathological fracture. And also sometimes will lead to spinal compression as well. Of course, we do a chest X-ray as part of our diagnosis, which will show the parenchymal involvement and the pulmonary hypertension respectively by doing the chest X-ray and the echo. Of course, the diagnosis also can be done by the markers, the diagnostic markers. There are several diagnostic markers for patients with Gaucher disease. And these markers is either become elevated or become decreased. The markers that are elevated in case of a patient with a Gaucher disease is the glucoceramides, the angiotensin converting enzyme, the tetra-resistant acid phosphatase, and the ketotrioacidase, and the chemokine ligase, ferritin, and GABA globulins. The most frequently used was the ketotrioacidase and the chemokine ligase, which is the CCL18. And both of them, they go with the activity of the disease, increase with the activity of the disease, and they are used also as the markers, not only for the diagnosis, but they are also used markers for a response of the treatment and improvement of patients on ERT. Nowadays, of course, we have the new marker, which is the lysosomal GP1, or they call GL1. This is a diagnosed biomarker. It reflects the severity of the disease, and it plays a very important role in advancing the personalized therapy of the Gaucher disease, and also has been published and identified as the most effective biomarker of Gaucher disease monitoring nowadays. Of course, we confirm after we establish our diagnosis by the level of the enzyme. Then we confirm our diagnosis by doing the genetic test, which by the GPA gene. GPA gene is it has like an 11 exons. It's found in the chromosome number 1 in the long arm in 2-1. It means the second piece, the first part of the second piece. So many mutations have been identified in the gene, and they found also there's some genotype-phenotype correlation. Means certain phenotype it gives you a certain genotype it gives you a certain phenotype. For example, the N370S substitute is associated with the non-pathological, non-neurological type 1, and the L44P, or they call it L448 now P, is strongly associated with the neuropathic disease. And of course, there is, as we mentioned before, the cardiovascular type is associated with this mutation, this type of mutation, the D409H. So that's why we said there is a genotype-phenotype correlation, some genotype and phenotype correlation. Of course, there are several factors that affect this kind of genotype and affecting the phenotypic expression of the severity of the disease, even in identical twins. So there is some the effect of other genes or the effect, other modifying factors on the expression of the gene. Of course, when we do the molecular test, we have two options. Either we go to the GPA gene if we have the enzyme is low, or if we have more differential diagnosis, if we are suspecting more other diseases other than the Gaucher disease, then we go to the multiple gene panel. Of course, the GPA gene, when we do a sequencing of this gene, it will give you 99% the pathogenic variant, and while the deletion and duplication analysis, it will give only less than 1%. So mainly sequencing of the gene is the one that will give the pathological changes in that gene. Of course, there is a publication regarding the changes that happen, the changes in our patient. And there's one publication done by Dr. Ozan in 2003, which showed that the Gaucher disease, and because at that time there's when our first medical genetic department established by Dr. Ozan, who was receiving patients from everywhere, from all over the Gulf. So he published that this mutation is the most common mutation in the Middle East. And of course, there was another population by King Fahd Specialist Hospital, publishing about in 2008, publishing about 12 patients, and they found that L44P is common mutation in our area, and actually 4 of them are Syrian of this patient, and all the others are Saudi. So these are the mutations that found in our population, which is of course different from the population found in Ashkenazi Jewish These are the 4 mutations that are found in the Ashkenazi Jews that approximately responsible for 90% of the cases, but for non-Jewish, of course, account for about 50 to 60 of the pathogenic variants. Of course, there was another population by Dr. Ayman Hijazi, where he mentioned about the number of the patients of Gaucher disease, 75, and mentioned that the type 1 was 45, and the type 2, 4, and type 3 is 26, indicating that type 1 is the commonest type in our area, luckily. So at least there is a treatment. But of course, there's a lot of underdiagnosed cases, I think, especially in adult cases, because in pediatric, we always consider the storage disease as part of differential in any patient with splenomegaly or thrombocytopenia or hepatosplenomegaly. But I think the cases more are missed in those adults who continue for years, and there is a delay in the diagnosis of these patients for maybe 10 years or more because of unaware of the disease in adults, and they think always that the Gaucher disease is a disease of a pediatric age. These are some of the algorithm that's suggested by the article for the diagnosis of in both adults and pediatric for patients with suspecting a Gaucher disease. And this is also a common before pediatric cases where we found if there is any prenatal hydrops, dermatological changes, erythrogryposis, colloidal, if there's any changes like cholestasis also, cytopenia or splenomegaly or colloidal baby, then suspicion should be there. Also, if there's any abnormal albumin, splenomegaly, cytopenia, and organomegaly, spleen alone or liver anecypline, then we should go and take a detailed history about the family history and about the consanguinity and history of fecal losses, which is known to be in a lady who has who is a carrier for Gaucher disease, and her husband is a carrier. Then the Gaucher disease embryos tend to get aborted. Then we go for the enzyme activity as well as the secretin, and then we can confirm our diagnosis by the GPA gene, and of course depends on what result we have, and then we can go either for a therapy of the Gaucher disease or we go for palliative therapy if Gaucher type 2. Of course, as part of our diagnosis, when we diagnose the family with a Gaucher disease, and we put these patients under 2 choices for the next pregnancies. It's either a prenatal diagnosis when the mother gets pregnant, either a planned or unplanned pregnancy, or we ask them to go for what's called a pre-implantation genetic diagnosis. So the prenatal diagnosis, we do either a chorionic villi sampling that's done between 9 and 11 weeks of gestation, or we go for an amniocentesis at 16 weeks of gestation. And mainly we either give the choice to the mother to get pregnant, and we can do these tests for the babies, and preferably as early as possible. So she should report to us immediately when she's pregnant that she's pregnant, so we can proceed quickly to do the chorionic villi sampling, or if she was delayed and she has some kind, which happened in all majority of our patients, they're so scared, and so sometimes they delay in telling us or informing us that they're pregnant, and she came late in the 2nd and the 3rd month of pregnancy. Then we go for the amniocentesis. Also, this is a good choice. Also, the prenatal diagnosis for the mothers who got unplanned pregnancy. So either she gets it planned, and then if the fetus is affected, she has a choice to abort or to continue of type 1 and get the treatment very early. But of course, for type 2, there's no treatment, so she can't have. They can discuss their choices. The family can discuss their choice and give us their final decision. Of course, we depend when we do chorionic device sampling or amniocentesis, then we depend on the DNA mutation rather than the enzymatic analysis, because enzymatic analysis has a lot of false negative or false positive results, but DNA is more accurate. So we prefer that we have the genetic test for their previous child or their current child who's on treatment, and then we go ahead and do the chorionic device sampling or amniocentesis based on the DNA mutational analysis. We can offer also the mother, if she doesn't want to get pregnant and then get aboard and all this stuff, we can provide her with what's called pre-implantation genetic diagnosis. And in this case, also we use the DNA mutational analysis. We ask the mother will be referred to the IVF tubal baby to do a tubal baby, and then the mother will be given a lot of stimulant medication. And this to get at least 5 ovum. These 5 ovum will be mixed with the semen of the tubes. So that's why it's called tubal baby. And when the embryo reach at this stage, a stage of 8 or 16, where getting one single cell will not affect the development of the fetus. And then we have to test all the 5 embryos. And those who are, of course, affected will be discarded. Discarded, like those ones, or those who are normal will be implanted, and you can implant more than one embryo in the mother uterus, and then go ahead with the pregnancy that is with the embryo that is free of the Gaucher disease. Okay, of course, we talk about the diagnostic delay that may take up to 10 years, and most commonly, of course, we see that one in adults. And this cause has a lot of impact on these patients. It causes premature death from the bleeding complications. It causes them pulmonary hypertension, liver cirrhosis, give them cause them sepsis, growth retardation, complication arising from the advanced bone disease, the severe osteopenia that they suffer, and the fractures, and also will affect the quality of life of these patients. Of course, when we diagnose these patients, so we take all these measures that mentioned, all the screening, the enzyme, the genetic test, the skeletal survey that we mentioned before, the biomarkers, all this. Then if this patient is for treatment, then we plan to do them on, for example, the biomarker, the ultrasound abdomen, the skeletal survey, the liver function, and the PT-BTT, and the DEXA scan. We do it every 6 months for these patients who are under treatment. And we do it for the bone MRI. We do it every 12 to 18 hours. Every 12 to 18 months, because we know the delay response of the bone to the treatment. And of course, in the long-term treatment, then we do the long-term treatment. We do this when the patient has been in the treatment for a long time. Then we space these investigations. That the DEXA scan and the biomarkers, they do it every year. The liver function test and the ultrasound abdomen still can't, we do it every 6 months, while the MRI of the bone, of course, we do it every 3 to 4 months. Of course, the management, I will not go into details because I think Dr. Hala, she has done a good job in getting that, and the goal is to reduce all the accumulation of these the toxic substances, prevent the progression of the disease and the devastating damages that happen because of the disease, and also to optimize the growth of these patients. And of course, as Dr. mentioned, the ERT, the enzyme replacement therapy, the substrate reduction therapy, which is the miglustat or iloglostat, and also we manage according to the symptoms for the cirrhosis of portal hypertension or pulmonary hypertension. Also, there is nowadays just still under the experimental what's called the chaperone therapy, which is a glucosamine that failed to improve the folding of the remnant enzyme, the remnant enzyme, and help also to improve the response of the enzyme. the current enzyme that the patient is receiving. So it's these are still they show actually improvement, and they show a better response with the chaperone plus the chaperone plus the enzyme replacement, especially for those who have CNS complications. Of course, gene therapy is still also under experimental. The idea behind the gene therapy is where you get the normal, you implant the normal gene in a retrovirus, and we use this retrovirus as a vector to transfer the normal GPA gene, and we put there in the bone marrow of the patient. And it shows, of course, that it has been done in the mouse, and it has shown a good production of the enzyme in the mouse macrophages. Still, of course, these we expect to be, hopefully, it's the future management for those patients of Gaucher disease. Of course, then a supportive management for the skeletal problems, for the pancytopenia, and of course also screening for malignancy. And in our hospital, he presented at the case presented at the age of 5 months. He was admitted to the ward because of abnormal movements of his head. He's always having a retroflexion of his head, putting his head in opposite position. Also, he was found to have a low blood count, and he has a loss of appetite for the last 3 weeks before the presentation. And he was admitted under the hematology, and the hematologist has consulted us to rule out any metabolic causes. This patient was a product of full-term normal vaginal delivery. He has a normal development milestone before this presentation. The child was born to parents who are first cousins, and they have an older daughter who is normal. And there's no report in the family from mother's side or the father's side with any patient or a child with a similar problem. On admission, a patient was looking slightly pale, but not febrile, and examination, he has no palpable lymph node, but he has a spleen just palpable, and no hepatomegaly at that time. He was noted to have a repeated attack of retroflexion of his head, like taking an oppositons posturing of his head and neck, and otherwise the child was very alert and reactive and responsive to his parents. Other systemic examination was normal. His hemoglobin was 9, blood white cell count 5.2, platelets was slightly down with 26. So, and the peripheral film saw only a microcytic hyperthermic anemia. There is a slight increased AST with normal ALT and normal PT and PTT function. The bone marrow aspiration was done to rule out any hematomalignancy, and the sample was diluted and not suitable for reading, and there was reported no Gaucher cells because we asked for a Gaucher cells. So enzyme assay done for both Gaucher cells, Niemann-Pick, and as well as Wallman disease. And patient was seen in our clinic after 2 months because the enzyme assays and the genetic test take about 3 to 6 weeks. So the mother, then when we saw her at our clinic, she reported that these attacks of retroflexion of the head is more, and he's not focusing, and the interactivity is decreased to the people surrounding him, and he has some peculiar abnormal eye movement. She cannot explain it very well. And when we she gave us also a video that she made at home to show how's the eye movement. And his physical exam, he was pale, looking really pale, and he has now a significant splenomegaly, which a river was there with the 5 centimeter, and the spleen was about 6 centimeter below the costal margin. And here is the video. All right, there was a video with the abnormal oculomotor apraxia, that the child has difficulty in horizontal eye movement. The video was very nice, and unfortunately, so we get the results then of the enzymatic assay that was low. The GP1 was Perfect, thank you. So we can see that he has an abnormal horizontal arm movement, and of course, we should show us this video. Okay, I think it's enough. Yes. So we can see very clearly the abnormal horizontal arm movement in this patient, reflecting the oculomotor apraxia that he has. Also, he has an upward gaze palsy of eyes, so he cannot raise its eye up. So we get the result that confirmed the diagnosis of Gaucher disease. And we have this, the common mutation that we have, the leucine 44P, or they call it for 83P, the same mutation. And he was, of course, negative for the Niemann-Pick disease. And then, so after stabilization, actually he was during when we get this result, he was already admitted to the MCH hospital, which is 20 minutes from our hospital, and he was having an abnormal, he was admitted with lethargy, and he had like a recurrent apneas attack. And that's why he needed to be ventilated. After that, he was after a while, he was stabilized, discharged again, presented again to the same hospital. He was stabilized, discharged, and readmitted with the same symptoms, and again stabilized, discharged, and he presented to our hospital. According to them, that the CT and the EEG was normal, so they consider as just a central apneas from the brain. Not as seizures, but when he admitted to our hospitals, he started to have seizures. These seizures was very refractory seizures. He was initially responded to his anticonvulsant, but later on he did not. Require more and more anticonvulsants. He required about 3 or 4 anticonvulsants, and of course, at the end he died with chest infection and sepsis. So, summary: Gaucher is the cause of autosomal recessive storage disease. It has mimicked several other storage disease, neurodegenerative disease, or hemato-oncology disease. So diagnosis is easy by doing an enzyme assay, biomarker, and a genetic test. And the treatment is available depending on the type. Is type 1, of course, and type 3. Early diagnosis is very important for a better outcome, and of course, family prevention program is very important to prevent the recurrence of the disease in the family. And of course, if you have any patient that is suspected to have a Gaucher disease or other storage disease, then you can just contact, can screenshot of this slide, contact the people. For those who does not have any the filter paper, the DPS, so you can screenshot this paper, this slide, sorry, and then contact the people. Go to Rare Disease Nexus, register there, and ask for the filter, and it will be reached to your hospital to do the enzyme assay and the genetic test for free for any suspected patient. Thank you very much, and I apologize for the delay.
Thank you so much, Dr. Rauda, for such elegant and distinguished talk, really. And just for the time's sake, please put your questions in the question and answer box, and we'll do it at the end. We'll answer it. Now, can I introduce the third speaker? In Arabic, I can say it ختامها مسك. دكتورة فخر زهير الأيوبي. She's a double master certified pharmacist in King Khalid University Hospital, and she had a master in clinical pharmacy and research, master in the business administration, double board certified, board in pediatric and adult clinical poisoning management, board in heart failure. Currently, she's the president of Saudi Pharmacy Specialist Group at the Saudi Heart Association, and she's a pioneer in utilizing metabolic syndrome pharmacotherapy. She's a pioneer in everything. She's the one who raised the idea of doing a rare disease webinar series, and this is the first of this webinar series. So just for the sake of time and no further ado, the floor is yours, Dr. Fakhr.
Thank you very much, Dr. Ghada, Professor Ghada. Thank you, Dr. Rauda, and of course, Dr. Ayman. Thank you for our audience for being with us in their weekends in such a very crucial, actually, time to be with the family. At the same time, they want to hear about the rare disease and how do we tackle these problems and this kind of disease. Honestly speaking, it's really nice to talk after Dr. Ghada and Dr. Rauda. You made my life easy. Now everybody, I think, knows about Gaucher itself. And the other thing is diagnosis and the management and so on. Here, actually, I'm trying just to landscape about something very crucial and important for pharmacists, because we are here for a reason, of course. Some of them will tell me, so what would pharmacists add? As simple as that, we are going to focus on a very important point, which is the pharmacoeconomic part. What do I mean by that? Please, just go with me in these few slides. I hope that we will not make it hard for us after this very informative presentations that we had, but just to give you a little bit of a glance of a pharmacist and clinical pharmacist in Saudi Arabia. It has started a few years back, more than 40 years now, as a clinical pharmacy specialty. From this, we can also talk about health economic. And that's why we want to focus about the economic part, what is going on, and what is the role of pricing these medications. As you can see, most of them are life-saving and sometimes even improving the quality of life of our patients. Let's go now, few concepts that we're going to cover. What is pharmacoeconomic? Again, we are discussing a very serious reservation that is talking and suggesting about the budget of any country. There's different concepts, there's different methods. I'm not going to go into complicated part, but what I'm going to talk about is the GDP, which is very important to focus on. Now, these GDPs are important that will tell you which type of country you are, which type of budget do we have. On the other side, of course, it's very important. It will tell us where are we spending our money. The other thing is that not all modules can be applied for orphan medications. What do I mean by that? Again, you really want a big impact, you have to take a big image. And this is a message for you to tell you about the importance of health economy. Again, money talks. Without money, we cannot function. After this pandemic time, even the rich countries, even the high economic countries are really hit very well. And it was a very painful hit for all of us. Now, let me talk about economy now from a health economy part. You can see now different countries have different incomes and a different, of course, level of expenditure on their health. When I'm talking about the importance of health economy, I'm talking about public expenditure. And again, measuring it according to the budget of the countries and the way they spend it on health itself. Now, again, different countries have different type of expenditure, but now I'm talking about health expenditure. For example, in Saudi Arabia, you can see now, according to the chart, GDP tell us that we have almost 4% of our budget spent on health. What do I mean in money? It tells us about $1,000 per capita is the budget of health in Saudi Arabia. Okay, that's important. Why? Because it will tell you which type, again, of country you are. Now in Saudi Arabia, we have almost like, again, for 34 millions, 35 millions. And you can see now the life expectancy in Saudi Arabia is almost 75 years. And the most important thing that we look at is now the birth rate and the death rate. Why? It will tell you the evolution of your population in order to reconsist or emphasize on the budget that you're going to put and allocate the proper budget for your population health. Now, in high-income countries, as you could see from the first curve, it tells you they spend more of their money on the direct cost. A module, for example, for chronic disease like heart failure, look at that, $70,000 are spent on the direct cost on those patients rather than the indirect cost. Again, we'll talk about this in details. Health, what is health? It's not anymore just a healthy person. It has to be a healthy person with a great quality of life. This is now the definition. And for that, we need a further research, we need a further cost of illness and burden of the disease, and of course, improving the quality of life of our patients. And that means the burden and the best bias. The other thing is that we need to reduce the economic impact of the non-communicable disease, and on the top of that, the rare disease. What applies to rare disease does not apply to chronic disease. What do I mean by that? First of all, rare disease is considered rare because it shows in a few number of patients compared to the population. For example, in the US, they will tell us that rare disease are 1 in 2,000 individuals. In the Europeans, as you could see, 5 in 10,000. Sometimes they will tell you there's an ultra even orphan disease that is 1 in 50,000. Again, definition depends on which country you come from, what is the percentage of the disease in the country, and so on. Another thing is the orphan medicine. Orphan medicine is a drug developed specifically to treat a rare medical condition. That was one of the questions that we asked you in the beginning of this webinar. So when I'm talking about orphan medications, I'm talking about specific treatment for a specific rare disease. And that is a unique thing. Why I'm saying that? Because in Gaucher, for example, disease in type 1, there's a multi-systematic disorder. So it doesn't treat only one problem, it treats the whole organs that are damaged from this disease. And in this case, there's some facts that we have to put in mind, that you will treat these medications differently. Now, the most important thing about orphan drugs is that only one molecule succeeds to the end when you compare it to 10 molecules. A lot of money has been invested, resources has been consumed to get this molecule to the clinical practice. The other thing is that there is incentives that's supposed to be developed and supposed to be applied in different countries. For example, in the US, when I'm talking about orphan medication, there has to be a 7-year period of market exclusiveness. Why? To make sure that these companies are rewarded because of the whole amount of money they put it on the molecule. And on the top of that, the corporate, the task also incentives is very important. In the Europe, no, they said it's 10 years exclusiveness, which is again, rewarding for the companies, and there should be a protocol assisting the reduced charge. The other thing is that some methods, we use it sometimes in the economic modules to measure the outcomes. QALY in a rare disease does not apply, which I mean that the QALYs by itself as a method to measure the outcome, or even using the ACER, which is, again, we're going to talk about it in details, is not the best way of actually pricing or budget making for rare disease treatment. Another thing is the cost-effective analysis. Now we have the Markov model, which is one of the economic models. It talks about the future events, and they just apply it on the future. They don't predict what will happen in the future. These markups and this cost effectiveness and these kind of modules will work greatly in chronic disease. But these modules will not be appropriate to apply it for a rare disease. Why I'm saying that? Because of the clinical challenges, few numbers of patients are on this disease. There's no long duration clinical trials done. Another thing, that the heterogeneity, you might not even have a 2-arm study, only 1 arm. The other very important thing is that the trial in the rare disease may be stopped earlier because of ethical grounds, and that will make it, again, a burden for the researchers and the companies to develop their molecules. The other thing here, that we have an unmet need in the rare disease that should be really considered. For example, in Gaucher disease, patients with this disease experience progressive and cumulative debilitation, and they might even lead to multi-organ damage, and this might even influence badly on their quality of life. The other thing is the early diagnosis, the better, but you could see from the slides before that it's very difficult sometimes even to detect the patients, to prevent the disease, and sometimes you cannot even prevent the severity of the disease and the complications, and it takes about from 4 to 10 years to get the diagnosis, which means already disease has done its job. The other thing is the premature mortality. And this is a very important slide and very important point, because this will take me to the second point, which is the challenges that we face when we are talking about economic modules in rare disease. Economic challenges are very important. We have a limited information for the direct and indirect cost in the rare disease, in the orphan disease. Challenges in development and comparative economic evidence. Again, as I told you, ethical points, number of patients, the design of the disease, the design of the studies, and so on. Most orphan medicine are not found to be cost effective when measured by standard thresholds for other chronic medications. High drug cost from sales to limited number of patients, because again, I know some drugs are costly, but again, it's only limited number of patients. And again, when you compare it to the limit information that we have, again, it will really have a very different impact. So these challenges can really prevent the accurate estimation of the proper performance economic modules in the rare disease. The impact of a wrong method, sometimes when you have a wrong method, like direct medication cost for the orphan drugs, what will happen? In this case, you will say it's a drug, okay, these drugs are really expensive. Patients will not have it. It will not be available. Practitioners will be limited. They cannot treat their patients. Again, complications appear in the patients. The quality of life would be really poor. The burden on the health will be even more and more because you are having more complicated patients. You are having more hospitalization for those patients. And sometimes even, as you could see, sometimes transplantation. So again, put in mind that we are, with these medications, regardless of the cost of this medication, preventing very complicated cases, sometimes even a huge burden on the budget of the hospital or even sometimes the countries. Cost of complications due to the more limited access to the treatment affect the healthcare system and patients' quality of life. So again, you're not providing these medications, you are having a very sick and poor outcome patients, a very poor quality of life. Some of them will start even as a pediatric age. And what happens? You will have a diseased child that will affect the quality of life of himself and his family. The other thing is that considering the assessment of orphan drugs, although these drugs are costly, but there's a single patient with a high comparative other disease. When you compare them to the total cost, as I told you, it will be a cost effective on the long run. So in this kind of disease, we have to look at the future, at the bright side, which is what are we really providing for those patients. The loop insurance patients' certainty is very important because now we are spending a lot of money in order to, first of all, screen the patients, support them with the proper enzymes, proper biomarkers, proper tests. Then after that, of course, education and tests. And then after that, diagnosis, then applying the medications on time. Now, the most important thing is the diagnostic part, honestly speaking. Now, if we are able to educate our healthcare practitioners, different specialties, you can diagnose early, great. You are doing a great job. You are stopping this disease from the complications. Education, again, is important for the patients, for their families, and of course, for the healthcare practitioners again. Patients also has to be educated. As you could see in some disease like Gaucher disease, if we are educating the families to get away from the problem of getting married to cousins and third cousin degree, that will really help a lot. Now, that's why we are here, and that's why we really started this wave of rare disease. We are working on putting policies in Saudi Arabia and, of course, in the Gulf country in order to have a policy analysis for rare disease and ultra rare disease. We are trying, of course, to cope with the MENA and, of course, globally in order to have a health technology assessment unit. This unit is supposed to work on the rare disease policies specifically. On the other side, they have to be joining also with the global international World Day. And on the other side, we have to work on registries. Very important to have our local registries and correlated with the international registries in order to make sure that we are doing a good job. Now, again, as I told you, a simple exercise. When I'm talking about direct cost, this is, for example, for a chronic disease. We're talking about the number of visits the patients will really come to different specialty even. You have a pharmacist, you have a physician, you have a nurse. All these people has a cost per visit. Also, this is not enough. We're not talking about only chronic disease. Now we're talking even about rare disease, which means that patients might have even admission and might even go to the ICU. Sometimes, as I told you, they might have even a transplant and so on. So you should consider also the number of visits to the hospital, consider the type of medications they have to take, the methods and the diagnostic materials we have to use. All this has to be considered. Again, this is all under the name of direct cost. When I'm talking about chronic disease, I can really know the direct cost, and sometimes even in rare disease. The most difficult part actually to detect is the intangible cost, which is the indirect cost. Again, talking about pain, quality of life, stress to the family, stress to the mother, stress to the kid himself, and so on. This kind actually of cost we cannot predict, and it's always like assuming what will happen. That's why we said, okay, in this case, we're not going to use the original methods. We're going to use the value-based pricing. What do I mean by that? Now it's an individual pricing because of the value of having an early diagnosis of this disease. And of course, when I'm doing that, I'm giving the price for the medications accordingly. Now, value-based pricing is a reward for the pharmaceutical companies and, of course, the pharmaceutical device companies in order to reward them of the huge amount of money they had, also in improving the quality of patients' life, putting in mind this is will really give us a measurable network economic benefits for the long time and for the future. Value-based pricing, which I'm going to use and I'm going to talk about, it depends on the income level, affordability, because if I'm not able to buy this medication or service, again, game over. But it talks about affordability on the other side, about the product or the service, whether this service, I can afford it or not. Now, what do I mean by that? Again, for example, if in the economic theory, value-based pricing, when a payer will be able to pay for a product or a service, match with the payer pays. What I mean by that, for example, if I have a cup of coffee, a mug of coffee, and I'm going to say that it's going to be costing $3.5. If the payer is going to pay the 3.5, that's it. So he is affording this. He's able to afford this number of dollars, which means now I'm matching my value base with the affordability part. The other one, it's very important. We have some tips that we have to work it up. And that's why actually in pharmacy now we are trying to get a union, a national policies to keep it simple. We don't want to complicate things. It's very important. Focus on the appropriateness of this service or this drug and this care for this patient. Keep the transactions cost and reasonable levels. Again, as much as we can, we don't want to underestimate the drug cost, but on the other side, we want to afford it for the patient. What do we mean by value? Again, we mean by value, it's the highest possible gain or outcome that comes from the patients. The early diagnosis, for example, the proper management, the proper medications. And this is really very important, that measure the total cost of care for those patients. So I'm talking about, first of all, we said the service, the availability, the affordability, the appropriateness of this service to my patients. Now, the other thing is, if you do this equation, you can see now add value for a patient. It talks about appropriateness of the service or this drug or whatever, and then you multiply it by the outcome of your patient with the cost per cycle. If this equation is done, you are able to price your management in a proper way in the rare disease. Program fails for the stakeholders if it drops one of the three elements for the pricing: the patients, the pharmaceutical companies, and the payer. So you have to do an equation between those three in order to give a variable and a viable and a value-based pricing for this service. Although the process of value-based is promising, it still needs more and more to work it up, because it really wants us to have more data on the long term. And of course, it has to be done in a very good equation so that we are able to get the medications done and to measure the outcome of our patients, and of course try to save the molecule from generics or alternatives till they get the profit that they put it already in developing the molecule itself. The challenges is very important, because before we used to just measure the safety and efficacy of the product. Now it's not only that, we are also needing to have a positive patient's outcome. If you have a drug and this drug will, let's say, decrease the hospitalization, this is actually something that's very difficult to measure, but this is how you do the value-based pricing for your patients, especially in the rare disease patients. The value elements specific for orphan drugs, QALY is not the captured one for now. And because of the absence of course, treatments, unmet need, the higher pricing of the medications, and the low budget impact sometimes, the long-term benefits, it's not even available as a data. So again, cost effectiveness is not the proper way of measuring the orphan drugs outcome. Also, another thing is that the evidence and the elements of value basing in orphan drugs, sometimes, as I told you, the trials are not to the point of full clinical trials, which means I have to be measuring the outcomes and again, reassess the number of patients that we have and how many do we have in our country and so on. So we have to have an expert, and I do really believe that historical controls is very important. We have to have also other countries involved in. we really need to match with international registries. Also, reimbursement is very important. Risk sharing is absolutely important. Also, make sure that we are working on the ACER part, which is very important in those medications. As you can see now, the upper part is the cost difference. On the right is the high cost, on the left is the low cost, and effectiveness also is on the right, the best effect, on the left is the least effect. So the best thing is to go in the lower cost with better effect. But again, is it applicable? Is this concept really going to work with rare disease? This depends on how you apply it. Just a little exercise before I finalize my presentation. The Gaucher disease, for example, they have the specific treatment, which has a cost specifically, and there's a supportive therapy. These enzymes that we were talking about, and we really covered them very uniquely and nicely with Dr. Ghada and Dr. Rauda. These medications has a cost, of course, and we have like 1 or 2 injection per month, sorry. And what's the cost overall? Now we have a long-term use of these medications, and it showed for us the clinical improvement in those patients in all aspects of complications of this disease. This kind of improvement is very rewarding. The other thing is the quality of life now. As I told you before, it's not only the outcome, we also need to know the quality of life that has been proven on the 4 year of evaluating our Gaucher disease patients, that when you compare them after 4 years, you can see the improvement that happened in all aspects and all signs and symptoms. So that tells you that in this case, the direct treatment has proved that it's effective and it's given us a great outcome. What about the supportive treatment? Again, you take them one by one. You talk about the Gaucher itself, the diagnosis, and of course the diagnostic tools and the cost of that, which Sanofi in this case has really did a great job, and they have already sponsored it by themselves. So it's not going to be cost for anybody to diagnose at least. But what about the multi-organ involvement? What about the condition and later on disorders that happens to the patients, biomarkers and so on? You put them on the top of the medication cost. Now that makes sense. Again, the other thing, there's nothing called a supportive care in general. It has to be individualized. It has to be also according to the symptoms, the quality of life of your patients, avoid polypharmacies, and make sure that you are providing the proper therapy for the Gaucher disease on those patients. In the end, avoiding the complications and of course the end results, which is transplantation. After I do all that, I can get you the value-based pricing for the Gaucher disease and how we can evaluate all medications under this and beneath all these equations. Cost-effective, as you could see, is not the proper way of using in the rare disease equations because of several reasons. One of them, as I told you before, in the orphan disease, the regulation and the standards of clinical outcome and efficacy will not be applied in rare disease because, again, these drugs has its own data and its own trials. So it's not easy to get even the outcome. And on the end, the quality of life also sometimes is very difficult to get in those rare disease, and which might affect in the end the alternative treatment options for your patients. And rare disease really proved in the healthcare spending, although the drug itself, it might be expensive, but the net results or the outcome are really different and has a different measurements. So I do believe that in rare disease, it's better to have a multidisciplinary model, a model that talks about, again, different specialty and the physician part, also the labs, also the genetics, also the nursing, the pharmacist, and the pricing people. So from pharmacy point of view, we have to make sure the drug is available, make sure we have the right drug and initiate it on the right time for the right patient, avoid the drug interactions and complications, avoid the delay of medications for some patients, and of course, achieve the target therapy that we need. Make sure that patients and their caregiver are well educated and counseled, because rare disease is a lifelong disease that will not just be treated and that's it. Follow-up of the patients is very important with the lab result, especially in rare disease. The contraindications and intolerance and complications has to be educated and has to be emphasized. And of course, in the end, as I told you, the cost of the modules that we're going to use in those patients has to be specifically created for them. In the end, we need to document this. We need to have, of course, a policies that is published and people can use it all over the kingdom and in the Gulf countries. Again, education is by itself a budget that we have to also consider when we are talking about cost of orphan medications. In the end, many treatment of rare disease, and this is actually the message that I want to transfer to our audience today, that rare disease by itself, it's a limitation, and the efficacy and safety is not the only limitation for us. Also, the quality of patient's life is very important. Affordability of these medications are very important, and necessarily approval of these medications are really important. There's some limitations in the data that we have in our patients because of the low number of patients sometimes, or the duration of the disease itself. Again, some patients might be diagnosed in the childhood. We have to have a policy, a pathway to tell us about what can we do in improving and development of policies that will take care of the patients till the end of their lives. In the end, both clinical expert and patients groups can help providing prevalence and potential uptakes of treatments estimated. In the end, I do believe that national-wide policy to deal with rare disease and ultra-rare disease are crucial, important, and that's why we are here today to try ourselves at first to educate how to screen, diagnose, manage the patients properly, make the therapy available, follow your patients. It's not just giving the medications, we have to follow them. We have to have a full program to follow these patients. And now it's just not just you do your job. You have to make sure that you are doing it properly. This is what life is all about these days. And I really want to thank you very much for listening to this presentation that took us a lot to prepare, because again, it's not an easy task, but it's just a tip of the iceberg for the rare disease and their medications. Thank you very much.
Thank you so much, Dr. Fakhr, for your elegant presentation, which is we usually expect this from you. Frankly speaking, you emphasized in a quite proper way the unmet needs in such rare disease, and you spot the lights. How can we manage such rare disease? I invite all the attendants, which I am so proud that we really exceeds the 130 attendants, to put their questions in the question and answer box. And we have a question from Dr. Samira. Is it wise to treat the neonate or infant diagnosed with Gaucher? I mean, regarding the severity of the disease presenting in this age and the cost. The first question, I can just direct it to Dr. Rauda if she likes to answer it, and then the cost to Dr. Fakhr.
Yeah, thank you very much. And thank you very much, Victoria. It was a very excellent presentation. And I would like just to comment regarding when we talk about the gene, and we said there is a genotype-phenotype correlation. And we said that the diagnosis started with family history. So if we have a family history of this family, and we know that they have type 1, yes, we can start this medication at the neonatal period. But if, for example, like the case I presented, it's type 2, treatment will not be of a benefit. So definitely I will not start this patient or coming from the same family who has a type 2 presentation, because we know it's not, in ERT, it's not of benefit for a type 2 Gaucher disease. So it goes also with the genotype-phenotype correlation for these patients. But is it possible to start at the neonatal? Yes. We've done it to many of the lysosomal storage disease. Those who have a positive family history and they have another child with the same disease, then we start, yes, at the neonatal period. But all, of course, in Gaucher, yes, it depends on what type. If we got it from the family history or we get it from literature, whether this type is type 1 or type 2.
Yeah, that's why we have to be, minded by the importance of early diagnosis, and by putting an algorithm for the proper diagnosis, as you just mentioned, Dr. Rauda. Thanks for your answer. And for Dr. Fakhr, what about the cost?
Again, as I told you, the value base is now your limitation, because it's not an easy decision, honestly speaking. We're talking about different types. We're talking about also outcomes. If the patients could be treated early, and it's really going to stop the complications, why not? We can go with that, because as you could see, some of them even will be like a burden on their families, and sometimes even will have more and more visits on the hospitals and the place they go back to. So from general answer, it will not have a general answer, but it will be individualized according to the type, according to the drug you're going to use, and according, of course, to the outcome I'm looking for.
Perfect. The next question for Dr. Ihab, it is directed to Dr. Fakhr. What is the limitations for orphan drugs pricing in Saudi Arabia?
The big limitation that we are facing that we still until now don't have regulations or let's say a standard way of pricing our orphan drugs. Again, it's like individual, each orphan drug goes by itself, and then we face the Saudi FDA and then different practice and different patients, which I believe that's why we are here for. We're trying to do these webinars in order to summarize it all in December, the coming December, in our scope 21, which will really take us to this place that we need to nationalize our orphan pricing medications, and this is for rare and ultra rare disease. Collaborate with different specialty in the country, not just pharmacists, also physicians expert in this field. They will tell us, they will guide us how many patients they will expect. For example, in Gaucher, for example, you said now 57 is not an accurate number. So you as an expert will tell us what to do. You will guide us to what type of disease you are looking for and number of patients we are actually targeting. Then the companies in this case will have a clear pathway telling them what to do and what kind of pricing we are looking for. At the end, of course, the end user, which is the practitioners and of course the patients, will have their life easy. And then it's like, again, any orphan disease will go with this pathway, 3 months, 4 months, that's it, drug is there. Rather than just waiting for each one to make it or not to the end and to the pricing and approval part.
Really wishing you all the success in the webinar series for the rare disease, because I think it's a very, successful step in Saudi Arabia just to raise and put spotlight on such rare diseases. Wishing you all the success for it. There's another question for dear Dr. Rauda about the diagnostic genetic report stating the types of Gaucher disease, if type 1 or 2 or 3. Is it available in Saudi Arabia by your experience?
What type? It's the same gene. So as we mentioned before, the same answer, like that we have a genotype phenotype correlation. So it depends on, we go, of course, it depends on our experience as well as if this mutation is a new mutation that we didn't know about it, we can go to the literature and find what was that case or what was that type. Okay, but we can get it from our patients. I mean, this mutation goes with the, for example, type 1 or type 2, or if this mutation we wouldn't have it before, and this is the first time, then we can go a literature and see whether this one is a type 1 or type 2 or type 3. Okay,
totally agree with you. Yeah, it depends mainly upon the clinical manifestations.
Yes. Otherwise, it's the same gene, the same enzyme, the same marker of the disease. It doesn't differ though. Even some of them, they were suspected to have type 3, for example, but till the older age, they still have no CNS manifestation. So it differs from one case to another.
Yeah, and upon this
yes, and just want to have one comment to Dr. Fakhr. I really enjoy your lecture, but I think the policy to measure the quality of life of these patients and how it's improved is very important, especially for those whom we start the enzyme at the late stage. I think measuring some of these patients, they didn't have that much benefit of the enzyme in matter of quality of life. So I think a discussion has to be put after these measurements of policy after to measure the quality of life is whether to continue these enzymes or not, or just to stop it. Because we face resistance from without data, we face a resistance from the parents to stop the medication, although we see that there's no improvement. But we have to have it as a measure, a real measure in our hands that to tell the parents, you can see these are the measures that we follow, and this is what happened. Otherwise, we find a lot of resistance, although they're so happy with even a minimal change in their son or their daughter. So they hold taking the enzyme, although it's not that benefit for them.
Sometimes stopping the progression of the disease by itself, it's improving the quality of life. I will not go like a little bit back, but you're not going to the severity of the disease. It could be another way of measuring it. That's why it depends on, again, as I said before, and thank you for your comment. It's very important for us. That's why we're talking about having experts like you in putting the proper policies. Sometimes stopping the progression by itself, it's a measurement. So we can also count on it.
Yeah, I totally agree. Yes.
Yeah.
We have this one in a lot of storage disease that it's not it does not improve what had been done before, but it's not like a Lysosomes. Lysosomes improve whatever disease you have, but others they just stop the disease where it is. When we start the enzyme at that point, then stop the progression, for example, of the eye problems, stop the progression of the cardiac problem. This stop progression, we consider it, yes, as this is it's a gain for the patient. But if if there's when we see like some symptoms and signs that it shows that though he's receiving the enzyme, but still the disease is progressing. For example, he started need, for example, some ventilatory support at night, the disease, though he's an enzyme, but the disease is progressing. And this case that I think it puts us in a big dilemma because we have no policies. Okay.
Yeah, so that's the point of our webinar today, actually, is like to individualize, especially orphan medications and disease according to the experts and the patient's outcome. And I'm so happy to take this into a second level to make our own policies, Dr. Rauda, and I'm so glad to have you, and of course, Dr. Ghada, in order to specify these policies according to your patients and according, of course, to the outcome. Which takes me to the question, Dr. Ghada, if you don't mind, because I'm sure we still have the questions for the voting system. There's a question telling us which is more cost effective in the hormone replacement therapy. Now, again, some drugs, and I do believe it. I'm so happy to have this question. And of course, I do want to thank Sanofi for sponsoring our meeting. Now, again, some drugs are like, again, you might have one or two in the field, not more than that. Again, they are costly. But if you have some companies who might even have an extra service provided on the top of the drug itself, this is by itself, it's considered cost effective. Now, I know from your talks and from Dr. Rauda talk that Sanofi had their own programs in diagnosing the patients, and they are taking the burden of the cost of such a diagnosis. On the other side, they have their own also programs in education. And this is very important because by time, if you really calculate this on the top of the drug cost, it's more cost effective than any other products. This is how we measure it also. Again, I'm not going to say this one is better than the other, because there's no head-to-head study, we know that. But again, if you have an extra service done by such a company compared to another company, and of course the availability of the drug. I don't want a drug that's available today and I cannot get it for another 2 or 3 months. So availability, affordability, as I said in my lecture, and in the end, extra services that will prove the quality of life and the outcome of your patient. If you don't mind, Dr. Ghada, if we can go to the voting questions so our audience can go and enjoy the rest of their weekend.
Just I want to add to your talk that totally agree. Having this dry test, which was explained in details, making our life much easier in diagnosis of Gaucher disease, and thanks to Sanofi for that. Now it's time to repeat again the pulse question, as Dr. Fakhr just mentioned, to see if the answers differed from the beginning. This as an element that we succeeded to just declare our clear points of view in the Gaucher disease. So please, we'll put again the pulse question, and I advise the participant not to leave us and to share with us in the answers, please. So the first question, the question which was answered before, what are the possible symptoms of Gaucher disease? Fatigue, distended abdomen, increased bruising and bleeding tendency, bone fractures, or all of the above. I will count from 5 just to save time and to have the answer. So 5, 4, 3, 2, 1, 0. So the answer which is correct is all of the above, and we have
almost made it.
Yeah, so we reached our okay, the second question, please.
Our audience are okay, great.
Okay, type 1 Gaucher disease involves all of the following organs and system except liver, spleen, lung, bone marrow, central nervous system. Again, type 1 Gaucher disease. Please answer. So 5, 4, 3, 2, 1, 0. Good, great. Good. It is
Dr. Ghada,
anonymous.
you did a great job. This is your part.
I'm happy. That's why I'm laughing. I'm happy. Okay, let us see the third question. Thank you for all the participants who stay with us till the end, which is a good number, really. So the third one, which cells is lipid-laden in Gaucher disease? It's a little bit tricky question, but I'm sure that you will tell now the proper answer. Is it the macrophage? Is it the lymphocyte? Is it the monocyte? Is it the plasma cell or the neutrophil? 5, 4, 3, 2, 1, 0. Great, the macrophage. This is the proper answer. Thank you so much. Let us go to the other question, the next one. The gene of Gaucher disease, is it GBA? Is it GAA? Is it GBE1? Is it GBAP? So let's have the answer. 5, 4, 3, 2, 1, 0. Great, Dr. Rauda. Great. MashaAllah.
Excellent.
Yes.
MashaAllah, great.
Yeah, MashaAllah. So can we see the next one? Thanks for the participant who remained with us. So the diagnosis of Gaucher disease is established by, is it clinical features? Is it elevated biomarkers? Is it enzymatic assay for the glucocerebrosidase enzyme? Is it the genetic test of GBA gene? This is a tricky question, so please answer properly, okay? Is it 5, 4, 3, 2, 1, 0?
Yes, diameter first. Yeah.
Dr. Rauda, you want to type to just comment?
Yes, just the diagnosis established by the enzymatic assay, established but confirmed by the genetic test. This is the proper, but it's whenever you have a low enzyme, then you have a diagnosis. With the high biomarkers, then it's a diagnosis. Yeah.
Thank you so much. So let us go now to my dear.
I think it's the term established and confirmed. These terms should be, you should have differentiate between these two terms.
Yes, it is established by the enzyme level and confirmed by the genetics. So the answer is enzymatic level and confirmed by the genetics. Okay, it's a borderline and tricky question. Let us see the next one, please. So pharmacoeconomic pricing, which I get benefit from Dr. Afak's lecture, and I will answer with you. Pharmacoeconomic pricing for orphan disease and drugs are by number A, Markov model.
Markov,
B,
yeah, model.
Yeah, B, cost effective, C, cost analysis, D, value-based pricing. So,
of course, now everybody knows the answer because it has to be a value-based pricing.
Okay, so Dr. Fakhr is nice to cheer us. Thank you, Dr. Fakhr. So let us see the answer. She gives us the gift of the birthday today, huh? Okay, what's the answer?
See, you'll see 100% giving the right answer.
Thanks for the gift.
See, 45%.
Still, yeah, you didn't hear the answer. Okay, let us go to the last question and the last gift. So what is an orphan medicine? Is it drug developed specially to treat a rare medical condition? Drug developed to treat patients? Diagnostic test developed specifically to a rare medical condition? Orphan drug that's still not yet developed. Let us go. 5, 4, 3, 2, 1, 0. Oh, top. I will leave you to just comment, Dr. Fakhr.
Yeah, you see, it's again, I know it's a difficult question, but that's why actually we're doing these webinars. Orphan medicine, it's always talking about development of a specific treatment for a rare disease condition, and it's available in the clinical practice. Like you see, D, it's still not yet developed. This is not right. It's developed, it's there in the market, and that's why we're giving it the patency of 10 years in the Europe and 7 years in USA. They will not have other molecules or genetics that will at least protect them from taking the whole amount of money of they paid for a development of a molecule. So the proper answer is supposed to be the drug developed specifically for a treatment of a rare disease and rare condition that is available in the practice also. A is the proper answer. We almost did it, but diagnostic test, it's not a medicine. Again, it's a test. So orphan medicine has to be a medication, or of course, a medication that could be enzyme, could be treatment and so on, but it has to be correlated to medications. Okay, great, very good.
Thank you so
Well
much,
done.
Dr. Gaucher. I just want to thank Sanofi company for that. I thank SCCP under the management of Dr. Fakhr for inviting all of us. Thanks, Dr. Rauda, for such elegant speaker. Thanks, Dr. Fakhr. And I will leave the theater for Dr. Fakhr just to finish it. Proud of having participant 125 till the end. Thank you so much, Dr. Fakhr. The floor is yours.
Thank you so much, Dr. Rauda. Thank you so much, Dr. Ghada. And of course, a big thank for Dr. Ayman, who had to leave us because of other commitment. Thank you, Kunuz Ritaj. And on the top of all that, thank you our participants for being with us, giving us also the motivation to go to wave 2, inshallah, in the rare disease. Our rare disease that's coming is again one of the interesting topics that we're going to cover it also, inshallah, with Kunuz Ritaj under the, of course, umbrella of the SCCP. I'm hoping that we will have you, inshallah, again. Thank you for giving us your time in your weekends, and see you very soon. See you, and wish you all the luck and all the happiness. Take care.